Today, we are talking about health systems responses, and we've got Amélie Quesnel-Vallée, who is jointly appointed between the sociology department and the medical faculty in epidemiology. And I'm not going to say anything more except to thank Amélie again very much for doing this. So without further ado, let me turn things over to Amélie Quesnel-Vallée. Thank you, Amélie.
Thanks, Chris, for having me. And hi, everybody. So today I'm going to be talking to you about monitoring health systems response, the opportunities that we've been involved with at McGill through the McGill Observatory on Health and Social Services Reforms, notably, and other things that I've been aware of as I've been diligently looking at Twitter and what's going on in the broad world out there. So obviously, with the COVID epidemic, one of the first hard-hit institutions has been health systems. And at McGill, with the Observatory on Health and Social Services Reform, we've been pretty centrally positioned to look at that. Notably, we are part of a global network that, and we mean by that, through that, to put Canada and Quebec on the map, because, and it'll become clear why when we do multi-jurisdictional analyses. So we are linked to the North American Observatory that Greg Marshall-Don and Sarah Allen lead at the University of Toronto, and through that to the European Observatory on Health and Health Systems and Policies. And they are themselves the European Observatory linked to the WHO Europe. So this is a big, broad network, and it is meant notably to make sure that health systems and in this case, their responses are being monitored. At the Moser, the McGill Observatory, part of our initiatives are to facilitate comparisons of health systems performance. So that's why we've also been very closely linked with those initiatives. And oops, I'm skipping over, sorry. And so just to put in a quick plug, we're also involved with training and with knowledge exchange. So we our goals and our mission are very much in line also with that of the Max Bell and what you guys have been learning and being interested about all this year. So what I'll talk about today is an initiative that is led by Peter Berman at UBC, that means to bring people across from across Canada and across the world, researchers really, together to start thinking about how have systems responded to this crisis, the COVID crisis, and which ones have been most successful in doing so. Now, I'm going to temper that, of course, to say, first of all, that this is going to be a hard task, determining what initiatives have been most successful and what systems have been most successful. And hopefully I'm going to unpack, using this conceptual framework, why it's so difficult to make that assessment. So first of all, the 4 levels that Peter put to us. Here we have at the first level, the top level, are the macro political, social, economic conditions. Of course, COVID, SARS-CoV-2 is a virus. At its core, it's a biological phenomenon. But when it rips out in societies, it becomes a social phenomenon. And its interaction with social factors we have seen, and we're going to continue seeing, I'm going to propose, is going to be really profound in years to come. So looking forward then, we really want to understand what are those institutions, and the governance structure that has allowed for the most effective action. Then at the level 2, we're starting to drill down into countries and looking at the organization and governance of public health institutions within health systems, because they are also part of those infrastructures and institutions. Then at level 3, we're getting, again, we're funneling down to more specific interventions. So here we can start looking at the actions. When was a country under lockdown? Sweden was technically not under lockdown as much as we were in Canada, as we are in Canada in many jurisdictions. Or what are the other interventions? When did they lock down? Was it earlier, later, at which phase of the epidemic? And then 4 is really, that's where we want to see the return on investment, is the effect of those interventions on the epidemic progression and on the social and economic conditions. And here pointing to the fact that we want to look at averages, of course, but also at the distribution. Again, COVID is working through societies in and very much along fault lines of age, of course, we have seen, and vulnerability, but also socioeconomic fault lines. And so the distribution, where is COVID hitting hardest, is going to be really critical to focus on here. And so I'm just going to unpack a little bit in the rest of the presentation what those 4 levels mean and what we've been working on, especially at the, sorry, this is not in the right position, what that means for the various institutions. I'm just going to skip over here. You didn't see that. So on level 1, we have the macro conditions pre-COVID-19. So these are the conditions that will facilitate or impede action, especially on the global scene. So first, we had the economic context. So we had global supply, we have had global supply chains that focus on optimization and low cost, and we're seeing the limits of that right now. As for instance, we have just realized now that we need them, that there are just 2 companies making nose swabs in the world. And they so far they were doing well in supplying the world, but now that countries are closing down their borders, that they're under existential threats, there are some constraints on those supply chains. Then we had a situation of prosperity, slash in some countries, finally a recovery from the Great Recession. In many instances, especially in North America and Quebec, in Ontario, and some parts of the rest of Canada, we were in a situation, the heady days of full employment. That is, of course, wonderful when it's happening. But when we then hit another type of crisis, we now realize, as we see in the long-term care facilities, we realize that those workers those jobs that were the least desirable jobs were actually being understaffed, chronically and structurally underpaid, understaffed. And when the crisis hit, we saw what the consequences, terrible and actually deadly consequences can be. Now, so that's at the level of countries, global, but also the country level. In terms of global institutions, we have, of course, the World Health Organization and its capacity for investigations, declaration of pandemics, guidelines and recommendations, and now coordination of vaccines. So they just announced that yesterday on the 18th, or 2 days ago. The WHO, when we compare the situation of SARS, the first epidemic in 2003, 2004, to SARS-CoV-2, this one now, we see that actually the WHO is under much greater constraint on its action, its capacity for action. This is not just the WHO, so there may have been some leadership factors at play here, but also there was definitely some conditions that had to do with a more global secular change that we're seeing, where supranational institutions are being challenged by member states. And of course, the WHO we're seeing now is being challenged very, very strongly by the US. But also, we can take another supranational institution of the European Union that is also, as the UK and Brexit shows, was also being challenged. We're seeing the rise of nationalism and populism, and that tends to speak against those national bodies and the coordination, the global coordination that they can enact. On the positive side, though, we also had a strong wake-up call from SARS and from MERS. I can speak about those other viruses in the Q&A, but that led to kind of a reaction and a taking stock that led to the Coalition for Epidemic Preparedness Innovation, so CEPI. They've been hard at work from day one in developing a vaccine and coordinated action across countries. So on the one hand, we have some supranational bodies that are facing challenges. On the other hand, we see the emergence of these other kind of startups that are trying to coordinate action in a way that is very promising. But notice that you probably haven't heard very much about CEPI, but they've been very, very active a little bit more behind the scenes. So maybe that's part of their success. To go further on that, I'll point you to work by Stephen Hoffman. So he's been at York University. He's been very active in studying that. At level 2, we look at the level of public health organizations, and this is where the partnership that Peter Berman is setting up is probably going to make the most headway in terms of research, because this is where we need more information. So what we don't have currently, and you might be surprised that we don't, but even at the level of the Canadian level between the provinces, we don't have a very clear view of a harmonized, kind of standardized data that allows us to compare the public health organizations across our provinces. So this is work that this slide is sourced from is adapted from the Canadian Public Health Association, a reflection piece, a white paper on the future of public health in Canada. And essentially what they point to is that we need some clear guidelines in the sense of where the provinces lie in terms of the legislation and the regulation. And this is true of all the countries, all the jurisdictions that we look at. It's just that at this point, we're kind of thinking provinces because we do have several natural experiments going on at the level of provinces. So what are the roles, the responsibilities, and the structures of public health organizations? And this relative to their core functions, what is their organizational performance, what are their human resource capacity, their system critical mass, and their surge capacity. You've certainly heard those terms, surge capacity of hospitals, but also of public health. Contact tracing is an extremely demanding labor force intensive activity, and it needs to be performed fast. In big cities, in Montreal, they don't have the capacity they haven't been able to ramp up the capacity. Part of the reason for that, and this is also true of Ontario, is that public health functions have suffered major cuts in past years. In Quebec, over the past 10 years, at some point they suffered a 30% cut during the budget year. In Ontario, they also suffered major cuts in the previous year. So when everything goes well, public health seems like it's this extra thing. But when we're in a crisis, it's difficult to then ramp up the capacity in a moment of crisis. And then we have leadership. So what is the role of the chief medical officer of health and of local or regional medical officers? And this is where I'm going to skip back. So this was my slide on leadership, which you can pick your leader, your public health leader. So of course, at the top right, we have our national Quebec Dr. Arruda, and bread in his effigy, and then in the middle, Dr. Bonnie Henry, my own personal that I think is doing a great job. And also, she's had a shoe made in her honor, and then of course at the bottom, Dr. Fauci. So the leadership has been of those officials has really been at stake here in their capacity to carry the message. And then we can ramp that up. Of course, in Canada, we have the public health officer, Dr. Tam, who is also at her jurisdictional level carrying the weight. But yeah, so with very many different provinces, with different organizations, but also different stages of the epidemic, it's very interesting to see them try to coordinate at the national level. Level 3, interventions. We have, so again, as part of our network as the European Observatory on Health Systems and Policies, we can of course speak about the national level of interventions, but as is the case in Canada and in many other jurisdictions, the critical action is often happening at a sub-jurisdictional or at another jurisdictional level, in this case, and for us, at the level of provinces, but also municipalities. And so we have been part at the McGill Observatory of the COVID-19 Health Systems Response Monitor that the European Observatory has been launching. Here you see the page for Canada. So yeah, we have Canada being featured along with other countries, and the advantage of that is that you can compare those countries' response from around the world. That response monitor is what I will call a little bit more of a narrative monitor. So essentially there's a template, and I think here, yes, so I have the policy response you see here on the left. There's set categories of information that need to be filled out by each of the member states, in this case, their nations that are featured at this level. And so that allows for cross-cutting comparisons and a certain harmonization, but it's really very much a text-based kind of tool. So you get to see the story. The challenge, of course, is also to update when things are moving, sometimes on a daily basis, especially as they were between March 13 or March 11 when it was declared a pandemic, and probably April 1st, it was sometimes several times during the day, things were changing. So keeping that evergreen is a big challenge. But the upshot is that then you get some cross-country analyses, as you see here, where you can filter the content by clicking on the policy response. So what has a given country done and when on isolation, quarantine, and contact tracing? So that's not only useful for research and for setting up the context of the interventions, but also for thinking for decision makers who want to think about, where is a given country that looks kind of like us on a given set of parameters? What are they doing now that they are at a given set of the epidemic, especially if they're ahead of us on the epidemic curve? That can allow us to take a look and inspire ourselves. And then because we have the sub-jurisdictional situation in Canada, we have here, we've been contributing at the Moser with the Canadian reports. So the North American Observatory is linking to the Canadian reports, also subnationally to some provincial reports. So you can find those here. Then at a slightly different now, so we're funneling down. So as I said, the European Observatory Framework is a kind of a big narrative one. I think our reports are 16-page long, narrative reports dealing with in great detail about much of the of what's been going on. But that is not necessarily something that is easy to consume and also to compare. And so another tool that we've been contributing to has been the blog post by the Health Economic Policy and Law Journal at Oxford. And so those have actually taken a smaller, kind of more condensed brief form, where the maximum word count is about 1,200 words. And again, it follows a pretty standard format template, and the countries are being posted as they come along. We have the Quebec, here I'm showing the Ontario post because the Quebec post was submitted last week, and it's only going to come up sometime this week or the next. And as you see, so here we have a context where we could be comparing Ontario's response to Spain's response, to Israel's response, and all the wealth of other countries that have been featured here. Again, the question of updating. So these are really time sensitive. So you see that they are, they have a timestamp that is really pretty critical in terms of the evergreen nature of this information. And then finally, so finishing up the funnel on the most granular information, but also the one with the least, meat to the bones. The Oxford COVID government response tracker. So here, notice we're moving a little bit outside of just the health realm, and I think I'm going to finish on this is going to be my final message, that it's really critical to be thinking about not just health, but beyond health, how this is playing out. So the Oxford group has, at the Blavatnik School of Government, has been collecting this information for many jurisdictions on these here 11 indicators. They've also started the collection on right now they're just publishing on national institutions, but they've also been starting the collection on subnational institutions. And one of our collaborators at the Moser has been contributing for Quebec. So what does this indicator give us? Well, we have those, as you see here. So this is here at the bottom, you can see the date. So on January 23rd, this is an index of the stringency of government, the relationship between COVID-19 number of cases and government response. Here we have, obviously, China with a stringency index of about 40. And as time goes by, you see that the stringency gets larger and larger. And as time goes by as well, now we're on 12th March, so the day after the declaration of the pandemic by the WHO. Now the world is starting to go on lockdown or to start implementing physical distanciation measures. And we're heading into the height of the epidemic in many places on 18 March. So this is after we start in Quebec the full lockdown. Oops, sorry. And then finally, 29 March, you see this is pretty much the picture that we see now. Although as countries, here. Are heading out. Some countries are starting to head out of confinement. You start seeing down some blue here. That's starting again in Europe. But right now, this paints a picture. So the gray is at the lowest level, but you see that the picture now is one of a global, pretty stringent response. Level 4 is the effects of intervention, and on that, it's going to be really challenging to establish the effect of interventions. The key reason being that interventions are highly endogenous with case count. You see it here. So this is, again, data from the Oxford COVID-19 government response. So this is a comparison of 6 countries' responses to COVID-19 as cases rise. So you can see very clearly that the said response and the case rise are essentially in lockstep. So in black is the number of cases, and red is the stringency index. So you really have this is what I mean by the endogeneity. So as cases rise, so does the stringency of the intervention. So are we to say then that a more stringent intervention is better at preventing cases? There is going to be some hard questions being asked, and it's going to be difficult to answer them, obviously, in those counts. So where I do see some light at the end of the tunnel, as far as that's concerned, is where we're going to be able to exploit natural experiments. So to move towards more causal stories, we have to start really getting very creative. And just here to heed the words of Keith Humphreys, ranking countries on who had the most and least effective response rests on 2 questionable assumptions. So first, that short-term results will be identical to long-term results. So we're going to see some differences probably on the first wave of the pandemic versus the potential next ones. And the questionable assumption that there's no such thing as luck. So for instance, we take Quebec, the fact that we had a much earlier spring break, and one that is very tied, Quebecers like to travel for obvious reasons, and we're very tied to Europe, means that we were flocking over there. We came back, and for 5 days, we were going about our business. And I say 5 days because the spring break ended on March 7th. And the declaration of pandemic was only on March 11th. In between that, Quebecers had gone back to their schools, their workplaces, and were just going about their lives as, moving, especially in Montreal, in public transit, just as life as usual. And there is a fair chance, a high likelihood that a lot of community transmission occurred. And I'm going to show you some evidence of that to that point. And this before and without the testing that goes along with it, and before lockdown. And we know now that when an epidemic is moving as fast as it is, as COVID-19 is, with an exponential rise, 5 days does make a world of difference. There's data coming out of the UK right now, comparing the UK and Germany, showing that that is actually a significant difference in stifling the epidemic. And so what does luck have to do with it? Well, things like rainfall. So this is a preprint that I'm showing you. So again, I said the tweets, I would bring up some tweets. I do find that this is a really important, right now, it's a fairly useful source of information. And you're welcome to follow my thread. I'm trying, it's at Amélie Quesnel-Vallée. And I'm trying to share what I think is most meaningful, and sometimes if there's a game changer. So does early social distancing, we like physical distancing better, but that's okay, help? Well, here they used rainfall shocks on weekends before the county's statewide lockdown. And the bottom line is, yes, it makes a difference. And with the rainfall, you have a better kind of handle on the potential causality. So running down, now I'm about 5 minutes away from ending, running down the level 4 interventions. We're down to level 4. So what will be the effects of interventions? The first message is that the social context is proving critical in modulating the success of those interventions. The same way as the global state. So level 1, the capacity of the WHO to go into China now versus when during the first SARS epidemic is very different, and that made a difference of about probably 5 to 10 days that were very critical in this pandemic. At the national level, we have demography, especially age structure, population health, so the pre-existing conditions, and family relations. Do grandparents live with their children? Do they live in long-term care facilities? Older adults, I shouldn't say grandparents, but grandparents are significant in this case. Do they live alone, as they do in Sweden? So that will have a big impact on the spread and how the epidemic will play out. Whether there's trust in government, so whether those public health leaders are able to pass a message where their people believe their governments will do what's right, and then the social determinants of health, and that's what I'll end on because that's my area of research. On demography, so this was again a preprint that is now I think has been published, where you can see that the expected COVID deaths by total population. This situation in Italy is actually very much a product of an age structure that is one of the oldest in Europe and indeed around the world, where there are many, many, many more older adults than in other countries. And so when you standardize by the population structure in terms of the age rates, you see that Italy was going to be the hardest hit at any given level of the epidemic. In trust in government, so this is another initiative, data collection initiative that looks at trust in government in various countries. And you see that from green, so green has more trust and red has less trust. This is the share of respondents that think that the government has been untruthful. You see that there's a wide variation around the world, and that variation actually tends to correlate with how people have interpreted the messages. So you have the extent to which people believe that social distancing is ineffective, not effective. And you see that more trustful countries are congregating at this end, whereas least trustful countries, countries where people have less trust in their government are congregating at the less effective end. So it has a concrete impact on whether people will be following guidelines or not. Now, finally, moving to social determinants and ending on that, I just want to bring that perspective because certainly if any disease has ever shown the impact of social determinants, COVID-19 is the one. It has done what we saw with diabetes, going from a disease of affluence to a disease of deprivation. Diabetes did that over 50 years. COVID is doing it over a matter of weeks. So this is just a quick graph to show that about 50%, this is according to the Canadian Medical Association, about 50% of our health as Canadians is affected or determined by social determinants. And that means that when we consider what COVID is doing, we need to bear that in mind as well. And that is something that we need to use in terms of thinking about what the next hotspots are going to be. So this quick graph that a colleague in epidemiology, Jay Brophy, put together shows that the epidemic started here in the central part of the city. And these are relatively wealthy neighborhoods of Côte-Saint-Luc, Côte-des-Neiges, NDG, and Outremont. Côte-des-Neiges, NDG is a little bit more mixed, but Outremont and Côte-Saint-Luc are more wealthy. And now it has spread out in these northern regions for social reasons that I will explain later. And you see that it's really gone down as far as those central regions where it started out. So contrasting two tales of two cities. Outremont is a high-income, low-density neighborhood. And what you see here is that those, I want you to focus on the blue. So this is community transmission, the dark blue. It started early on. So this is travel. Essentially, people were out of the country. They came back and they had the virus with them. They got the virus elsewhere. France, Italy, Switzerland, and also some in Florida, probably. And contrast that with here, Montréal, which is a low-income, high-density, very, very high-density, one of the densest neighborhoods in North America. And what you see is that, and by the way, this is all post-lockdown, all of this, post-lockdown in Quebec. So what's going on here in Outremont, you see post-lockdown, the cases that were contracted pre-lockdown are showing up. And then post-lockdown, nothing. You just like stifle down. A little bit of healthcare workers, doctors, notably, probably exposed. And here, note this. So very low community transmission. So first of all, nothing at the beginning. And then as we move through time, it's rising and rising. And it's one of the hardest hit neighborhoods now. What's happening is a lot of those healthcare workers were working in, sorry about that, we're working in long-term care facilities, notably, low income, poorly paid, low protection, no PPE, no personal protective equipment. And they come back home to very densely populated neighborhoods and they have to go back to work the next day too. So they're not calling in sick. They can't quarantine, they can't isolate, the city is too high for that. And so what do we have now? Community transmission. So this is really social determinants at play. And what's more, Montréal is a very, it's racial minority, so Black, Haitian community. And we have actually seen that elsewhere. We've seen it in the States, and we've seen it also in the UK. So this is something that is playing out in many locations that needs our attention. And looking to the future, then we need to also think about what this will do to workers and to the economy more generally, which is a really important social determinant of health. So this is just a quick graph to show the COVID-19 impact on aggregate hours worked. So those individuals who have lost the most hours, lost jobs in pink, and lost hours in blue-gray, are the ones who are making the least money. So that means that those individuals would be at the greatest risk of impact coming the opening of the lockdown, because they're going to be willing to take a job, any job, probably, and potentially be again at risk of COVID if they weren't before. So the bottom line, monitoring health systems response is a big endeavor. It's a necessary one. We first need to look beyond the health system. Social factors are and have been intertwined at every step. Drawing causal answers, so this is the second point in the middle, will be very challenging. It's something that will require a lot of time and a lot of thought. However, we still need to understand, to have a grasp on what's going on, and other countries' experiences are a start. And so harmonized data on policy responses are critically needed, and they're being harnessed as we speak.